Good evening, everybody. Welcome to Call the Doctor. Pretty soon on the screen there'll be a number for you to call to remind you that if you have questions of either I, or my co-host Gene Kitchen, or our guest Dr. Lee Isley today, who we'll introduce officially in a minute, please call the number and ask your question. It's a live call-in show, and so please take advantage of that. You know that we've spent a ton of time blowing up the benefits of the hospital in our community, and that's UNC Healthcare. Today, not only is my co-host, who's a member of the board of the hospital, going to help guide us through some of the information we're going to introduce, but we have as our illustrious guest Dr. Lee Isley, who's the president and CEO of the hospital. And so our hospital is community owned. It is not part of the UNC system. Formally, it's really owned and operated by our community. And in doing so, the management of this hospital is accomplished by a board, which Gene will tell us about in a second. And then we'll introduce Dr. Isley, who will explain to us what the role of the president and the CEO of the hospital do. So Gene, tell us a little bit about what the board does at the hospital.
Okay, we have got a board of 14 now, I believe, right, Dr. Isley?
Yes, ma'am.
It was 12 for a while, but now it's 14. In fact, one of our board members is a county commissioner, Sue Leggett, but it's a wonderful board, and of all the various, and you know I like volunteer work that I've been on, it's the best board I have ever served on because the skill set, the amount of time that people are willing to give because they care deeply about our healthcare system is tremendous. And we meet quite frequently. We have subcommittees that we break out and work, but we help steer and guide, and Dr. Isley's very, very gracious about leaning or looking to us for wisdom and guidance and input, whether it's the financial, the quality measures, the strategic planning. We are kind of his eyes and ears in the community, the hospital's eyes and ears.
And you really represent the community. Tell us a little bit about that.
We come from all counties. We are represented by all counties in Nash County, male, female, diverse in every way, and diverse in age, diverse in ethnicity. But we all feel very free. We are all on committees, as well as serving on the board, and we meet the first Thursday of each month. And we always have a representative from Chapel Hill, from UNC, usually Dr. Alan Stiles. But you mentioned we are partnered with UNC, but not owned by them. And a number, and Dr. Isley will explain it, but a lot of the hospitals were purchased and are owned by UNC. But a board prior to the board, my serving on the board, elected that we wanted to partner with them. And he'll very gladly tell you all the wonderful benefits of that, but I mean, we still are Nash County started us.
Because what we've been advancing with every single show that we've done is how the hospital serves our community in many ways, and we're really going to get into details on that tonight. But it also, it's clearly has investment by our community and a broad spectrum of our community to help guide the administration of it. And I think that's an important point that Dr. Isley can help explain to us. Dr. Isley, please tell us your role in the hospital as president and CEO.
So I'm the liaison with the board. I partner with the board of commissioners and their vision and help operationalize that vision that they have for the institution through their interaction with the community. And so I help them facilitate that conversation and then operationalize that. Sometimes they're very explicit and the operations is easily carried out. Other times I have to help interpret that vision and help guide the organization, work with the medical staff, partner with the medical staff and our staff at the hospital, the allied health and the support staff to put their vision and their mission into practice. And so that's really what the role of the CEO does, is to help guide the organization.
Right, and probably, how many years have you been with us now?
4 years.
So 4 years, so approximately about 4+ years ago, the hospital, which was wonderfully managed historically, saw the retirement of the previous CEO, who did a wonderful job. But because of the amazing physical plant that the facility has, which we'll talk more about, the board, in their vast intelligence, really saw the potential for us, and then you elected to, as a board, to partner with UNC because of the advantages of linking with a state-of-the-art teaching facility.
Well, in the previous board, in fact, when Larry Tuning was there, they had already made the decision. I think maybe Vince Andrecchio and Ziggy Zalznick were involved in that decision, among others. But so we already had that in place, which was wonderful. But they help us recruit. They help us interview. Dr. Isley is an employee of UNC, and because we have other jobs and other interests, we needed their guidance and relied on them very heavily to know what we needed to look for. And a lot of that was we needed somebody to take us into the new, rapidly changing healthcare environment. Because as people probably know, our hospital has grown tremendously, but focused on the areas of greatest need in our community. But we needed a visionary. And I'll give you an example. Our leapfrog scores were in the CD range, which means our quality. When Dr. Isley was
CD meaning the letter grade,
the
C
letter
or
grade,
D.
like
so average or below average.
And I have the privilege of chairing the Quality Leadership Council, and we kept getting reports. This is what we're doing, and this way. And we said to Dr. Isley, we don't want to hear what's happening. We want to hear what's being done to make it better.
Right.
And now the last 3 scores for Leapfrog, which is being graded against hospitals across the nation, we've been A. And so he is a very action-driven person. And,
right.
and it's been wonderful because when we ask him to help make this change or help us attack this or tell us how he's preparing for COVID, he's got a great administrative team, and I'd like for him to talk about that too.
So let's go into your administrative team, but first tell us a little bit about your history and what attracted you to this area.
Well, I've been in healthcare management and administration for over 25 years. Have always been in rural healthcare communities in North Carolina, Western North Carolina, Tennessee, and then back in the Triangle area. And so I've spent my entire career in small to mid-sized communities and working with medical staffs and boards and organizations and helping them grow and see and fulfill their potential for what they can do and mean for their community.
And
so
I hear you got a grassroots start in healthcare. You were an EMT.
I was a paramedic before spending some time with the military, and I spent and then came back and spent some more time as a paramedic, and actually went up to the mountains of North Carolina to help a hospital bring in an EMS system. After being able to bring that EMS system in and spend a couple of years, the CEO was the individual who had hired me, asked me to come over to administration. And so I thought, well, didn't know exactly what that meant, but I thought, sure, we'll do that. So,
and you've always lived in the communities that you served, right?
Yeah, I believe very strongly. So my first job in EMS, we did not live, we lived adjacent to the community, and I realized then that you really needed to live in the community to understand it, and that's even more important and powerful in healthcare, and if you're delivering that healthcare and working with physicians and the sense of community and communication that needs to occur, it's hard to achieve if you're not immersed in the community and understand how the community works, talks, and plays together.
Right, and that type of interplay is important, particularly when you run a very complicated business as a hospital. And in operating a very complicated business as a hospital, I look at that as a captain of a battleship, or more like an aircraft carrier, something that's huge, that has the requirement of thousands of people to become operational, that has a vision, that has a goal, and that has to protect a lot of people. And then it's very expensive to operate. And can be in trouble if you don't do a good job. To do that, to exercise that vision, you really have to have an amazing team. And part of what you were hired for was that vision. And could you brag on your team for us a little bit? Because there isn't anybody who works at the hospital who doesn't interact with the physician management, with the non-physician management, were all very impressed by your team, which speaks volumes to you. But explain to us, who your lieutenants and sergeants are, because they truly do a ton of the work. And you've really assembled a group of people that deliver an A-plus product to our community. And so tell us a little bit about your team.
Sure. Well, and it really starts with putting what we call the administrative team or the senior team together, but it really is a much broader scope of leaders than just the administrative team. But certainly the individuals that I work with the most throughout the day is, my CFO, Sean Hartley.
That's a Chief Financial Officer.
Chief Financial Officer, the Chief Operating Officer and Chief Nursing Officer, Crystal Hayden, who really is kind of the quarterback of the operations of the day-to-day. Mary Strickland, who is the VP of Nursing, Davis Green, Dorsey Tobias, and Ann Schreiner, who is our Chief Medical Officer.
All sharp.
Just do an incredible job of bringing each other's strengths. Danae Dickens, who is the Executive Director of HR, is part of that team as well. And they all bring together and enhance each other's strengths, help each other when we have challenges, and give insight. And then, of course, we're supported by a whole cast of department directors and executive directors, leaders, both formal and informal in the hospital, who just go above and beyond each day, and the staff that take it upon themselves to make those decisions for their patients and help communicate with the physicians. And of course, to your point about the complication or the complexity of healthcare, it is really three components every day. There's the operations of the hospital, there's the person who has to take the x-ray or draw the blood, transport the patient, deliver food,
right.
Those things, and then deliver linen. And then there's the physicians. Some of those are employed by us, some are independent and have their own practice, own business, have their own revenue, and we have to coordinate that care when we don't necessarily have direct authority in that. And then there's the payer, of course, and then the patient. And the payer gets involved with us and makes decisions about the care that we can or that you can order, deliver, and how the manner in which we deliver it. And a lot of times that is not as transparent as it should be.
To the patient. Right.
The patient really gets impacted by that. And it's really about the discussions that are going on with the payers, the physicians, the staff.
There's a ton of work behind a patient's back, isn't there?
There is a great deal, and it's all being worked in many days. We do it seamless, and everything comes out. But certainly there are opportunities for us to have challenges or hiccups throughout that day. And you really have to know where they're going to come, plan for those, be proactive,
and know how to deal with
them.
Right, because collectively the community is served better if you do. But even on an individual basis,
right.
Somebody's insurance company may not approve a procedure
Right.
that their doctor told them they absolutely need.
Absolutely.
And the amount of work that goes on behind the background to make sure that they don't have a large bill.
That's right, and to get the documentation to support that
Right.
operation.
Right.
I can tell you that within recent years, though, and Dr. Isley, you said you've been here 4 years, we are hearing eyes and ears, and I'm sure you too, Dr. Perlmutter, wonderful things about the hospital. I mean, there was a time when people were not as positive about it as they are now, but I think we have come to a whole new level of excellence. In some of our, like cardiology and cancer, are actual branches of UNC Chapel Hill in our facility. I mean, how great is that we have a comprehensive cancer center and a just stellar heart center, and we'll get into some of the awards later on. But I'd love for us to pull up the profile, since he's kind of describing it and let people see like the 4 facilities and kind of the description. There you go. You want to kind of talk to us a little bit about that,
Sure.
Dr. Isley?
And many in the community know this. I speak to many individuals that were either born in the hospital as it opened, or their parents or grandparents were transferred over from one of the other hospitals the day that it opened, and I get to hear all kinds of interesting stories, and certainly I'm a student of history and enjoy hearing all about our background and our history. So we were founded in 1971, so we've been celebrated our 50th anniversary last May, so we're coming up on 51 years. I'm the fourth CEO. I think that's really a unique characteristic and positive quality of this health system is that in 50 some years there's only been four CEOs, and I'm the fourth. And so many of the individuals that I work with still tell me stories about Brian T. Aldridge, our first CEO, who actually oversaw the construction of the hospital. And so to be in an organization that actually individuals who still are working, who worked with the first CEO, is a very unique experience. And so we have 4 facilities. We have 3 licensed hospitals, but we talk about it in 4 facilities. Nash General Hospital, which is our acute and intensive care hospital. That's where most of our patients interact with us at and go for care. That's where the emergency department is, our surgery suites, imaging, lab, the things that we think of traditionally as a hospital. Attached to that is Nash Day Hospital. At one point in our history, it was actually a licensed hospital, but it's in the mid-late 80s, we actually moved it over into Nash General. But it is where we do all our outpatient. Prior to COVID, we did outpatient surgery there, but because of COVID, we had to consolidate into Nash General. We do have plans for opening and expanding back into Nash Day for surgery on a limited basis. We do our rehab, radiology, endoscopy. To our discussions earlier this evening, the Cancer Center is attached to Nash Day Hospital, kind of on the far end of the hospital. We have our behavioral health hospital located on the campus. It's across from the emergency department, across the kind of the field, and it takes care of behavioral health, psychiatric needs for our community, and does a really good job. We have continued to work and improve upon our relationship with our behavioral health providers in the community to ensure that our community has the services that they need. And then Brian T. Aldridge Rehab Center, named for our first CEO. Many of us call it BTAR. There, it is a 23 inpatient rehab hospital. It is across the street from our parking deck and near one of our, we call lakes there on campus. And so it is really a renowned, not only for our community, but across the region for the service that we provide there at the rehab hospital, and has been recognized by many third-party evaluation organizations for the work that we do.
And it's just a stunningly beautiful facility.
It is excellent. It is by and far. The pool, the dining facility, just everything was done top notch, and so continues to be in great shape there. The viewers can see that we continue to be a busy hospital. Our emergency department sees close to 70,000 patients. We're one of the busiest emergency departments in the UNC system. And so for a community our size, the emergency department sees a lot of business. And then we continue to offer many of the services that you would expect to receive in a larger area and town, but because of our proximity and the vision of the board, the medical staff's collaboration, we've been able to bring those services here locally in the community.
And with excellence, too. I mean, we're doing 1,200 cardiac catheterizations a year, delivering 1,000 babies, and are approaching 9,000 surgeries a year.
So that for the viewer, it's certainly hard to know if you're not in the business whether those numbers mean anything, but 1,200 catheterizations means that you're doing a lot of catheterizations for a community our size. It certainly means that the physicians that are doing those catheterizations have plenty of experience and are well.
And many of the patients are in fact coming from out of our typical service demographic because of the excellence. And that's true for our cancer center as well.
So certainly some of our services, we'll talk a little bit more. I'd love to talk about our orthopedics, our general surgery, cancer, and cardiology. And to your point, certainly in those four service areas, we're drawing outside of Nash County and drawing individuals who want to come for those services.
For the excellence of those services.
That's right.
Because they can, many of these communities, they can get those services quite locally. We're going to take a break now, but during this break, I don't want you running away. We're going to actually show two wonderful little videos. The first video is, and our second break in about 20 minutes is also going to show educational videos to really talk about some of the services that we offer at the hospital. The videos coming up are going to be on the community paramedic program and on our food pantry program at the hospital. And we'll see you on the other side of those commercials.
What the community paramedic program is a program that sends paramedics out into the community to help patients after discharge.
It connects the dots for them. He provides education and also to proactively take care of our patients. So evidence-based practice says that if the community paramedic sees the patient in the home, they're able to decrease the readmission rate. It just decreases the burden on the healthcare system.
Taking chronic patients, it takes a toll on all the providers, from the ED to med-surg, nursing, to the dispatch call takers. Some of the things that we do when we go out to residents is we will do vital signs, we will do medication reconciliation, where we take and look through all their medications. We answer phone calls. If patients have questions, we can help walk them through their needs. We can communicate with their doctors. Sometimes they'll make medication changes right over the phone, and that'll help keep a patient out of the hospital so they can be, at home and healthy. We do lab draws for patients who can't get in and out of the house. We do coronavirus vaccines. We've seen patients who were our high-risk readmitters who had been in and out of the hospital get their diseases under control. Most of the time they get a better understanding of their disease process and they're able to live a healthier life, which is what we want ultimately, is for the patient to be healthier.
Well, after he gets to the routine, he answers all my questions. And he takes the time. I mean, those heart doctors, they whiz in. They're so rushed. And you go, and they're gone. But Till takes the time.
I'm so lucky to have Mr. Till in my life, because if it weren't for him to come back and check on me and make sure that that I'm stable and able to go to my doctors and see what kind of meds I need, I won't have nothing.
He's a blessing. He really is.
So being able to connect with patients on a personal level and just talk to them and let them know that it's going to be okay and that you can be healthier, you can resume a good quality of life. I think that helps the community as a whole.
This is where the public would benefit if they had more Tills out there.
Honestly, I would really like to have at least 10 community paramedics to be able to cover our patients.
The more cars you have, the more people you can help, the more lives you'll save.
Our board has really put a strong emphasis on addressing social determinants of health, because we know if certain needs are not met, like food, that our patients and our community as a whole is just not going to be as healthy as they could be.
So the food pantry is for inpatients. So after they are admitted to the hospital, they will receive a visit for someone from case management. At that point, they will be asked a series of questions, and through those questions, it will be determined that they have a food insecurity.
When a patient is food insecure, they're generally having issues accessing nutritious food on a consistent basis. Through these boxes that we provide them at their time of discharge, we can ensure that they receive nutritious foods that are in line with the diet that they're on while they're here.
And this food pantry is very important for the patients who are living by themselves, who doesn't have that much family or community help. It at least makes them get by for a few days so that they can recover and get back to their work.
I will receive a report, and through that report, I will identify what diet-specific menu is for that patient. We have 3 different food pantry box options, one being diabetes friendly, one being healthy choice, and one being heart healthy. The heart healthy box will come with a blood pressure monitor cuff and a digital scale. Also provided in that box will be recipes, and there will be resources in the community so that you will know where other pantries are in your area.
So now they have the education and they have the tools to move forward and to eat the correct things. And then they also have that list of resources and other ways to get food. So they have that information, they have those tools, and our hope is that they, will continue to use that.
Really, I was thinking, Lord, I don't have much money to buy food. Should I get my medication, or I save it, or what? All the food. So if I got the boxes of food and stuff, I can go ahead and get my medication. I'm good. I'm blessed. I didn't have no problem with that. My mind at ease.
Actually, I've been doing the hospitalist medicine for the last 10 years. I've never seen any hospital with this kind of program. That's what really surprised us, actually. This really goes to who we are, actually. We're a county hospital. We're here for the county, and our goal is to improve the health and well-being of this county, and that this goes well with our goals.
Welcome back to Call the Doctor. Please feel free to call in if you have any questions. We're having today a discussion with Dr. Lee Isley, the President and CEO of Nash UNC Healthcare Systems. And would you continue your talk with us, Dr. Isley, and tell us about the relationship that we have with UNC? Sure.
I get asked this question a lot. We review it every 2 weeks at new employee orientation because it is a complex system. It's an academic system, as you know, and it really spans the entire state. And so a lot of questions about our relationship. As we've talked earlier, there are certainly individuals who believe or have believed that we are owned by UNC, and that is not the case. So in 2014, the Board of Commissioners for Nash UNC Healthcare decided to affiliate and become associated with UNC. And what that means is that we have local leadership, a local board of commissioners, local decision making, and our investments in this community, whether it's in new services or assets, medical office buildings, new CT scanners, MR, is all done by Nash, right. And we're responsible for our own finances. And so we get to tap into the UNC health system. As the viewers can see on the screen, it really does expand or span the entire state. There's about 14 different hospitals. About half of us are owned or affiliated, or owned, and about half of us are affiliated like Nash. And that really means that we're able to tap into the partnerships and the benefits of UNC. And so I think the next slide will talk a little bit more about what some of those benefits are. And so, for instance, the system, and we had access to Epic, at what we call Epic at UNC, and that is the electronic medical record that our nurses, our allied health, and our physicians use to chart and communicate about patient care. And the uniqueness of having it across the entire system is that if you needed a specialist at UNC, that individual can access that record real time while you're on the phone with them. So as their hospitalist or their physician is here in Rocky Mount talking and seeing the patient, they can actually access a specialist who can see the record in real time and read the chart. And so that has been invaluable. We have several different opportunities there that I've witnessed how we've improved patient care through having that connectivity.
And Dr. Prasada was talking about if a patient here needs to go for open heart surgery, that they can just seamlessly use that system to communicate with them, and often the doctors from here, because they are UNC employees too, follow them up there. But Dr. Isley, I want to mention when that system, the EPIC system came in, you have to be a certain size hospital to even be able to qualify to get to have it. And because we were affiliated with UNC, we got it, and we got it with the economy of scale, a better price point even because of them.
We did. We got a discount. I know that as I worked with the board, it may not have felt like a discount. Right. Still an expensive electronic medical record.
But they all are.
It is the lifeblood of the
But
hospital.
it is the lifeblood, and it was certainly, I have seen that not only from the patient care side, but the finance side, it was well worth the investment. And so,
Right. It all translates into the mechanism by which we talk to each other.
That's right.
Very effectively to deliver quality care. And without an effective electronic record program, we simply can't deliver the care in a timely or cost-effective manner.
And it's hard to communicate, and that certainly slows down patient care and leads to complications if there is any confusion. And so the other benefit is UNC Physician Network. We talk about this a lot. So it is a sister organization that has been stood up by all the affiliates and owned hospitals, and it helps us operate the day-to-day practice, our outpatient practices. So it helps us operate our urology practice, it helps operate the day-to-day surgery practice, our otolaryngology or ENT practice are just examples. And so they kind of take care of the day-to-day. Crystal and I are very involved in the strategic operations of that. We meet on an ongoing basis with PN to make sure that we're talking about how we expand services, what services we should offer, and those types of discussions. But the day-to-day, how you make an appointment, PN helps us operate. NASH is responsible for any shortfalls between the cost of operating that practice and the revenue it generates. So it really is our practice, but they're a vehicle that we use. That's their expertise. That's what they do every day across the state.
Did you mean by that if a practice is losing money but is providing an absolutely necessary service to the community, NASH eats that financial loss in order, but maintains that vital service
That's
for the
right.
community?
And that's part of what we do as a not-for-profit hospital system.
Right. And that's an amazing point because, for example, I'm not part of the UNC Physicians Network, but I provide services to the hospital. But there are some services that simply cannot support themselves as a private practitioner. For example, our trauma service. Right? Impossible to support yourself as a trauma physician by yourself, but to have the financial support of the hospital, even though there's times it may lose money. It provides an absolutely necessary service to the hospital. So if somebody breaks their leg, they need to know that somebody like Eddie Hasty is waiting there for them.
And I saw Eddie in the operating room this week, and there were 3 or 4 patients who did benefit from that service.
Every day.
Every day. So the others, cancer and cardiology, here are great examples of how our relationship with the academic medical center brings quality care that a community our size just could not afford or have the expertise that we're able to tap in to the expertise of an academic medical center. We may have a patient and a physician here locally. They may have a surgery at Chapel Hill, and then once the patient is able to be transferred back closer to home, that happens seamlessly because of that communication through the electronic medical record, through the cancer committees, and the work that we're doing every day. Cardiology, that relationship is actually with the School of Medicine, and so we're tied directly into the School of Medicine, and those physicians who are doing over 1,200 catheterizations a year are even doing more back at the UNC Med Center. So they're coming back out and are part of our community, but also have access to UNC. So those are some examples of how we benefit through that affiliation. And then, of course, the helicopter, we have a helicopter station, Tar Heel 4 is stationed on our campus and available for us in the region. And so
And that helicopter stays at our hospital.
It does stay at
Yes.
our hospital.
There's 2 helipads and 1 bird that's there all the time. And how many, there's 2 teams, correct?
That's right.
And a pilot sleeping, he's got quarters
Sure.
there, so I mean, we've had that going on.
So those
all
are
the
just
time.
examples of how we're tied into the benefits of UNC, but the final decisions rest with that 14-member volunteer board of commissioners who all live and work in the communities that we serve.
And UNC also lends a hand to us in recruiting physicians. I mean, we've added a lot of physicians to our community, like in surgery and others, and they help us recruit. And Dr. Isley, I want people to know when a new physician is recruited this area, they are asked to stay in this, or they're required to live in the community, aren't they?
So yes, so UNC does help. I work with Carol Batchelor, who is assigned to Nash as an employee of UNC. She lives here in the community with us, does a tremendous job in recruiting. I will give some benefit to UNC, they do help us, but Carol really has championed this. The board has been very explicit with me that they wanted physicians to live in the community. Mm-hmm. We've set up our recruiting so that those physicians are encouraged. As you've been with us, and Dr. Perlmutter, you know that the first physician we recruited, it was a little bit of a challenge to get them to live here, but we've recruited over 20 physicians over the last 2 years, and over 90% of them live in this community now because we are able to put them with individuals, their peers, who are raising their families here in the community, and they actually help us recruit more physicians in. And so it's easier and easier every time we recruit a physician.
Right. They have to go to our churches. They have to go to our grocery stores. They have to really invest into our community because
raise their families here.
Right. Have to do their banking here because when those things exist, the likelihood that that physician will stay are enhanced. Having an itinerant physician drive up from Raleigh to provide care and then drive back home is not the ideal situation.
And we're getting, I know there's several of my son's classmates growing up here who are back here, Dr. Pazak and Dr. Martin. And we are recruiting more. I mean, a lot of younger doctors here. Dr. Nelson, Dr. Clay Nelson's son has come back. So it's happening, folks.
So we are beginning to recruit some of our own native sons and daughters back, and so that's
who would otherwise go.
That's right, and it certainly is rewarding to be able to do that. And I think, you know, there are certainly some extenuating circumstances where the physician's not able to live within the community. And what I'm really emphasizing to the physicians that we recruit is that we want you to be a leader in the health system. We want you to help develop it and bring your voice to the table, and that's a challenge if you're not in the community.
If you would be so kind as to share cancer care, cardiac care, and surgery, and how we've seen those grow and how we're addressing a real need that was in the community and are actually even expanding the cancer center as we speak.
So we use a medical staff development committee that helps us guide. It's made up of physicians, board, and community members. And we do a third-party analysis of how many physicians of what specialty. And it really have been working with and partnering with Carolina Regional Ortho as an example, Boyce Willis, in how we deliver care and starting those dialogues about what's right for the community, what also benefits the practice and benefits the hospital, but that we need to take on as a partnership. And you know, sometimes when business gets tight, those conversations just kind of lose their focus because we all go back to our own corner and it's just easier. But the medical staff, Boyce Willis, CRO as examples, have been really good partners that come into the table with us in helping develop that. And through those partnerships, cancer care being one of those examples where we worked with Boyce Willis, we worked with Dr. Crocker and his group to bring cancer care into a single facility so that we could get economies of scale and work together. Cardiology is another example. We worked with Boyce Willis to help consolidate that, bring it into one practice. We have sites at all campuses, their medical office building, and provide services. And I think we're doing a better job for the community. We're able to consolidate. There's not confusion on the patient side, the physician side, and the staff side. And so I've seen tremendous growth in not only the volume and the services, but the quality. And so we certainly invite, the board has been very explicit with me about having third parties come in and evaluate us on how we're doing. The American Heart Association, the Stroke Association, American College of Cardiology are just some examples. Gene, you mentioned Leapfrog, certainly, which is for those viewers that aren't familiar with Leapfrog, it's a national not-for-profit organization. They call themselves a watchdog for American hospitals. And just as you mentioned, they give us a letter grade, just like we got in school, A through F. And certainly, just like in school, A's are better, and as you go down, right?
But they generally rate every single hospital.
They do rate every single hospital.
Right.
And so
there you
across
go. There's the A.
Yeah, so across the country, and there are a set number of parameters that they use. They change those periodically, but let us know what those changes are going to be. You chair the Equality Leadership Council, and you know that we talk a lot about and focus on how to respond to those measures. And so a lot of partnership with our medical staff, a lot of partnership with our staff and our board. And so to your point, in the last 3 report periods, which equals a year and a half, we've received an A, which only about 20% of the hospitals in the country receive an A. And so we're very proud of the work and that we have been able to make and realize. CMS rates us. We've been making improvements there. We've CMS.
You would tell what that is.
Yes, Medicare, Medicaid,
Okay.
Centers for Medicare Services, which oversees all hospitals who accept Medicare and Medicaid patients, which is in essence every hospital.
Right.
And they rate us on STAR systems. We made improvements there. They also either incentivize us with payments or hold payments back if we don't meet certain criteria. And we have been able to enhance over the last couple of years because of our performance with those measures. We've improved the reimbursement from Medicare and Medicaid by about $650,000 because of our quality improvements.
So delivering a better job gives us more money
That's
to do
right.
further improvements.
That's right. So
perfect incentive.
and then one of the things that we've just invested in over the last year during the pandemic that the board was very passionate about is the patient and family experience. And so we brought in a whole new team of patient engagement navigators. They are in the hospital 24/7. And they help work with our patients, their families, to make sure that we're coordinating care, we're communicating. And so it's, sometimes for us in healthcare, the forest and the trees, we're busy, the physician's taking care of multiple patients at one time, the office, there in the hospital. And these individuals help bridge that communication with the patients and the physicians, the providers, to make sure we're getting the information that they need to be successful as patients and make sure that we're focused on them.
And I want to give a testimonial there. I was just at the breast center for my annual mammogram, and my husband had surgery with Dr. Perlmutter. When I get those surveys, I really want to do my part to praise the staff because I know they work so hard, and I'm working in the hospital on the board. seeing that, and so I just give them the top scores across the board, just so that's kind of my way as a member of the community to say thank you.
Right, and not only do you do so because you're a member of the healthcare system, but they've
But it's
earned
true.
it.
They've
But
earned
it's
it.
absolutely true.
Yeah.
I see on a daily basis, on the floor and in the operating room and in the associated departments around it, people going out of their way, co-workers going out of their way to deliver an A-plus job. And if you interact with 10 people and they all contribute 10% to your care, and 3 of them fall flat, you end up with a 70, which is a D in any grade book.
Right.
Right? So everybody really has to step up to the plate to deliver that A, and everybody does.
Oh, they do.
They really do.
I know. It's very genuine when I said, I didn't have to wait very long. They were very nice. Everybody asked if they could help. I just can't say I couldn't have had better care.
One of the
they don't know
one
it
of
on the
the
board,
unique
so that's not part
features
of it.
of the CMS patient survey that you were referencing is that they asked for the overall rating of the hospital. It's on a 0 to 10 scale, and I tell people that by nature I'm an 8 kind of guy, right? Because 8's good, but it means that you can still have a little room for improvement. But I was really happy with the service. In the definitions of Medicare and Medicaid, an 8 is the same as a 0, so they only count 9s and 10s. And
Did you know that, Dr. Perlmutter?
I did not know that.
Yeah, I mean, you got to get a 9 or a 10, or an 8 is like a 0. So that's why I'm glad we brought that up, because I get 10 service when I go to the hospital, and it's not because they know I'm on the board, because they don't. I'm right there with a mask with everybody else. But people could not. I can tell that they are all doing the best job they can.
So if somebody
with
rates a
patient care.
hospital a 4 or an 8, it's functionally the same rating.
It is for as far as
CMS
is concerned, Medicare, Medicaid, it's the same. Now we know the difference and can separate that out a little bit.
But the point that I'm trying to make, though, is for you to have metrics that show significant gains, that means that we're getting rated.
That's right.
9s and 10s.
That is correct. So several years ago, we were in the 9th percentile for patient experience. That meant that 91% of the hospitals across the country were doing better than we were.
Wow.
We are now, and Gene has been helping us keep focus on this. We're now in the 60th to 66th percentile, which means that we have improved. The board has tasked me with getting us to the 75th percentile, meaning that of all the hospitals across the country, we're doing better than 75% of them, or in the top quartile. And that's where we're aiming to go. But in the 3 years that we've been really focused on this, that is a tremendous improvement. And it really is a testament to the staff's work, the partnership of the medical staff, and the board's vision of continuing to be insistent on what they want us to do for the community.
Right, and a lot of that, of course, is community perception. And a lot of that is what the hospital does for the community outside of the campus.
Correct.
Tell us a little bit about our community outreach program.
Sure. So one of the things that
and I think we have a slide on that, Lee, if you wouldn't mind putting that up.
So part of the strategic plan, we looked at 4 areas: physician alignment, quality and service, community partnership, and financial sustainability. Community partnership was really about getting outside the walls of the hospital and making a meaningful impact on the quality of life. So addressing what many of us will talk about as social determinants of health. These are the areas in which may not necessarily be directly linked to healthcare delivery, but impact healthcare delivery and the patient's ability to follow the physician's orders or to adhere to their health regimen. And so it's things like food insecurity, access to health care, safe housing, education, job opportunities, literacy, access to medications, and those things that aren't necessarily health care but impact health care. And they're so important in communities like Nash County, Rocky Mount, and small rural communities that we really wanted to make sure we were investing in it. we partnered with our Board of Commissioners and then the Nash UNC Healthcare Foundation. We partnered together and we embarked on 2 programs that we're seeing a great deal of success with, and I'm very proud of our ability to offer to the community. One was an inpatient food pantry. I think we saw a little bit about that at our break, and the work that Dee and Kirby are doing to make sure that we're identifying through EPIC those patients who come into our hospital as an inpatient who qualify or are determined by a survey that of questions, a battery of questions that they may be food insecure. They're offered a diet, medication sensitive diet of food to take home after they leave the hospital. Is for 3 to 4 days to feed, help them with their family and their food, so they don't have to focus on food, and they can focus on their quality of life improvement, rehab, medication.
Very often people will come home from a specific surgery and they can't have foods that they're not used to not buying. They just may have had stomach surgery, for example, and they have to have a different type of diet. So you provide specialty foods for people who require that, because sometimes they have to make a choice between medicine or food.
Sure. And
right?
we also link them up to other community food banks. So we've partnered. So this isn't a competition. This is, we're really extending and putting these individuals in.
Getting them started.
Getting them started, extending that and putting them in contact with other community food banks and services. Then our community paramedic program is made up of 3 paramedics that, again, through the partnership with the foundation, has helped fund. We identify either the physician, a staff member, or case manager may identify that the patient may have some additional needs after they're discharged. Our purpose is really never to discharge the patient, just help them transition from the hospital to home. And that community paramedic really helps that transition. So the community paramedic, I've had a chance to go out and shadow and ride with the community paramedic. The days that I went out with them, we talked about medication with the patient, how to take medication. We helped them. A simple example is we found a patient eyesight wasn't good enough to read their insulin measures, so we got them some larger lettering on their syringe, or got pre-filled syringes so they wouldn't have to do that. So those are small examples, but those examples, if they're not taken care of, is how a patient ends up back in the emergency department or back into the hospital.
Dr. Isley, I know also during COVID you partnered with the health department in a lot of realms and had clinics at Ward Tabernacle and Greater Joy. There were some people who even got COVID shots with a person went to their homes and gave them to them. So the hospital, people tend to think of the hospital, Nash UNC in one facility, but it has become so much more of a community hospital with the outreach. So,
Gene, we did partner. We had great partners with Greater Joy, OIC, Ward Tabernacle, or just a few examples. Many of the religious leaders and clergy in our community came together and helped organize their congregations so that we could interface and everybody had a choice about how to receive care. We call it the mobile vaccine clinic, and all anyone had to do was call us, and we would actually go out to them and to their home and bring the vaccine to them. And matter of fact, we would ask them to bring as many of their family over as they possibly could, so that and you know this, the way the vaccine worked, once you break that vial, you actually have 6, 7, 8 doses that you have to use, and you have to use it up. You have to use it up.
Terrible waste. Right.
So an example, and then another one that I'm really proud of the imaging staff, and Davis Green and Crystal Hayden were instrumental in this, was the Mammography Partnership with OIC. And so OIC had received some funds for the hardware for mammography, but we're needing to have access to the experience and the expertise of how to put the program together, right? So they had the hardware, we had the experience. And the state of North Carolina has a very heavily regulated program around mammography. And so we were able to partner, and now we're able to offer mammography services at the event center through OIC.
So
And
you took it to a neighborhood to make it very accessible.
And we provide the mammography tech, we provide the oversight for the quality program. Our physicians at Nash provide the reads for the mammography film, and so it's been just a wonderful partnership. So those are examples of how we're trying to get out and kind of break the mold of what it means to be a community hospital.
We are moving, we are running out of time. I do want to give you a chance to talk about the foundation, what they do with patient assistance and how people can call. We're going to put a phone number. You got it, Dr. Perlmutter?
I do. We're going to put this telephone number up. I'll read it out loud to you. And for those of us that wish to support the UNC Foundation, Healthcare Foundation, with your generous support, the number is 962-8583. Please help our community. Any money that you can give really does help your neighbor, and it's all of our part, to help support this foundation. In fact, we're not sure what we call this. We were talking to Sandra earlier whether they call it a challenge grant or not, but I will personally match the funds of any donations that come in if you mention this show for the next week, because it's going to replay about 3 times, I suspect. So up to $1,000. So if the community who's watching this show donates $1,000 and mentions this show, then I will match that and make it a $2,000 donation.
Wow.
So please help me help our foundation serve our patients better. 2 more quick points. If you think that you have COVID, do not go to the emergency room for testing. We have a telephone number that we're going to put up. It is 462-2071. Please call that number and they'll give you directions of where to go best for testing or for vaccinations. For healthcare, wear a mask. It's still the best thing that you can do when you go to stores and whatnot. Consider vaccinations. My email is going to come up in a second. If anybody is a fence sitter and not sure whether they should have their vaccination or not, please email me directly. I'll be honored to spend quality time with you, even over my cell phone, to talk to you about the benefits of getting a vaccination. Any healthcare need that you have, our hospital can serve you. Or the doctors and the other providers that are members of this community. At Nash, you can expect excellence, and we will deliver it, particularly because of our guidance of our board and the excellent administration that we have. And Dr. Isley, thank you very much for joining us tonight.
Thank you.
And Jean, thank you for all you do. And we'll see you in 1 week when we talk to Dr. Hobgood about anesthesia services at Nash.
Thank you.
Thank you.